Hello students, this is Dr. Praveen Tripathi and I will be taking up the abnormal psychology in the Conceptual Psychology app. I am a psychiatrist. I have done my MD from IHBAS, Delhi, and this is a crash course. It's going to be particularly beneficial for the students who are appearing for the M.Phil or M.A. Clinical Psychology entrance exams. Should be equally beneficial for those who are targeting the NET or JRF exam. Let us talk about the anxiety disorders now. Now see, all the anxiety disorders predominantly present with symptoms of anxiety. The classifications that we have created basically tell us that in which condition are we seeing those anxiety symptoms. Like say if somebody is having anxiety in social situation, we are calling it social anxiety disorder. If someone is having anxiety symptoms say in a closed space only, we are calling it claustrophobia, right? So depending upon the circumstance in which the anxiety symptoms are prominent, we have different diagnoses. These are the symptoms of anxiety, and I believe all of you must have felt these symptoms at one time or other, right? Like before the examinations, you may experience palpitations, you may even have hyperventilation, breathing fast. You may experience that your extremities are getting cold. They may be sweating. Some people experience tremors when they are anxious. In some people, there may be increased frequency of urination or diarrhea when they are anxious. So all these symptoms, restlessness, and the accompanying feeling of nervousness, which forms the psychological component of anxiety, these are the symptoms of your anxiety. Let us talk about the anxiety disorders. First of all, we will talk about panic disorder. Now, what is a panic attack? So panic attack, it's an acute, a sudden attack of intense anxiety. The patient feels so anxious that he feels that something untoward is about to happen. Some patients may come and say that they're feeling so anxious and they feel as if they're having a heart attack. Others may say they feel as if they're having a seizure. Some may say they are feeling as if they're about to collapse. So the anxiety symptoms are so strong or so severe that there is a feeling that some major event may happen. Often in the questions they give this phrase, feeling of impending doom, that something bad is about to happen. And all these symptoms are seen in patients who are having panic attacks. You have palpitation, difficulty breathing, chest pain, dizziness, depersonalization and derealization. What is the meaning of these terms? Depersonalization is feeling of unreality of self. Feeling of unreality of self. And what is derealization? Feeling of unreality of the world. We will understand these terms better when we talk about dissociative disorder. For now, let's just remember feeling of unreality of self. When you feel unreal, that is depersonalization. When the world starts feeling unreal, that is derealization. Now, repeated and unexpected. So if a patient is having recurrent and unexpected panic attacks, then we make the diagnosis of panic disorder. Recurrent and unexpected panic attacks, we make the diagnosis of panic disorder. So when they want to give you a question on panic attack or panic disorder, they will give you a history of a patient who has episodes of around 20 to 30 minutes. And they will say that the patient is having symptoms like difficulty breathing, palpitations, tremors, sweating, and thought that he's having a heart attack, right? And then they will say that these episodes are recurrent and without any stressor. What is the diagnosis? So we have the diagnosis of panic disorder. How do you treat panic disorder? With a combination of pharmacotherapy and psychotherapy. In short term, you give benzodiazepines, right? All these drugs, alprazolam, atizolam, clonazepam, the zepams drugs or the zolam drugs you give, you want to give these drugs for a short term. Why? In the long term, they are habit forming. They have a dependence potential. And in the long term, you can give SSRIs. And then the therapy of choice is cognitive behavioral therapy, right? So you will see that this is the treatment for majority of anxiety disorder. Pharmacotherapy, short-term benzos, long-term SSRIs, and psychotherapy in the form of cognitive behavioral therapy. But when we talk about phobias, we will prefer behavioral therapy. Now, these are some of the common phobias. Sometimes they may ask you, they may throw in one of these terms and ask you, what is it? When do we use this term? Fear of what is described as this phobia. So, nyctophobia is fear of dark. Agoraphobia is phobia of places from which escape is difficult, right? Like agoraphobia is fear of places from which escape is difficult, like fear of open spaces, fear of closed places, fear of traveling alone, fear of public transport, fear of crowded places. Of course, the last one is crowded places. Right? So, any situation where the patient feels that I would not be able to escape from this place, that is your agoraphobia. If the fear is only of closed places, we call it claustrophobia. Ailurophobia, cats, cynophobia, dogs, mysophobia, dirt, pyrophobia, fire, xenophobia, stranger, thanatophobia, death, hydrophobia, water, acrophobia, heights. Now, for all these phobias, again, short-term benzodiazepines, long-term SSRIs, but the mainstay of treatment remains psychotherapy. Mainstay of treatment remains psychotherapy, the behavioral therapy. Now, in behavioral therapy, we primarily use exposure-based therapy. Exposure-based therapy, and the two most important ones are systematic desensitization and therapeutic graded exposure. Right? So, systematic desensitization is where in a stepwise manner you expose the patient to the feared stimuli while simultaneously using something to relax the patient. Right? So, stepwise exposure while using relaxation techniques is systematic desensitization. If you do only stepwise exposure without using any relaxation technique, then that is called as therapeutic graded exposure, right? Basically, in therapeutic graded exposure, you allow the anxiety to die down, right? Say you do the minimal level of exposure, whatever anxiety patient experiences, the basic nature of anxiety is that it has to go up and then come down. Once the patient is exposed to that fear stimuli and the anxiety is allowed to go down, and the patient is able to then get exposed to that stimuli without having the same level of anxiety, then you can proceed to the next level of stimulus. Whereas here, the same stepwise exposure is done, but along with the relaxation techniques being used. All right. Now, in phobias, the anxiety was happening in a particular situation, right? We talked about a particular situation. If you look at the next disorder, generalized anxiety disorder, look at the name. The anxiety is generalized. The anxiety is not in a particular situation. It is not limited to a particular situation, but the patient is generally anxious. And here the Q, the buzzword, if we can use the word buzzword, is worry, excessive worries. The patient is excessively worried about all the domains of life. Say the person is worried about what will happen in the exam. Will I be able to pass in the exam or not? Will I get a good job or not? The person is worried about the finances. How will I manage the money? From where will I get money for the next important thing in my life? The person is worried about the health of family members. Parents are getting old. What if something happens to them? How will you manage that illness? The person is worried about relationship. What if my partner cheats? What if something untoward happens? So in different domains of life, the person is having a lot of worries. And if you're worried about everything and all the time, what will happen? You will also experience physical symptoms of anxiety. So The anxiety is free floating about all the domains, and then you start experiencing somatic symptoms of anxiety, right? You may be restless, you may feel restlessness, you may feel muscle tension. These patients often come and say that they're having pain in the shoulder, in the neck, headache. When they go to bed, they keep on thinking about these things. The worry thoughts keep on coming. So they have insomnia also. So restlessness, they get tired easily, muscle tension, insomnia, poor concentration, irritability, right? So if the question is saying that worry is in multiple domains of life, along with somatic symptoms of anxiety, we are going towards GAD. Treatment, again, short-term benzodiazepines, long-term SSRI, and most importantly, cognitive behavioral therapy. Now, there are two anxiety disorders which are usually seen in children. The first one is separation anxiety disorder. The name itself is suggesting us that anxiety is happening at the time of separation. So usually what happens is the child, when separated from parents, like being sent to school, starts developing physical complaints like abdominal pain, headache. First of all, he does not want to go. He does not want to go. Why? The child does not want to go because he has thoughts that something bad will happen to self. The child thinks that something will happen to himself or herself, or something untoward will happen to the parents. Right? He thinks that I might get kidnapped, or the parents may die if I get separated from them. So first of all, he avoids getting separated. But if you forcefully send him to the school, you will get a call from the school that he's having abdominal pain or headache, and the moment he comes back home, the symptoms resolve. This is the history of separation anxiety disorder. Selective mutism, again, the history is in the name itself. The child is not speaking in one setting, like he does not speak in school at all, but otherwise at home he speaks a lot. There is no problem. So the child is not speaking in a particular setting. The treatment is primarily psychotherapy only. Let's talk about OCD, obsessive compulsive disorder, which is characterized by the presence of obsessions and compulsions. So obsessions. So what are obsessions? A person will have a repetitive thought, or it can also be an image, or even an impulse. So say I am having a repetitive thought that my hands are dirty, my hands are unclean. Now this thought comes in my mind again and again, and it makes me uncomfortable, it makes me anxious. I am getting a thought, my hands are unclean, my hands are unclean. Now I know that this is my thought only. I know when we say the thought is a product of their own mind, it means I know this is my thought only. Why is it important? Say I come to you and I say that I get this thought again and again that my hands are unclean, but it is not my thought. My neighbor is using some kind of technology to put that thought in my mind. In that case, what does it become? It becomes thought insertion. But here the patient does not say that. Patient says, doctor, I know this is my thought only. I know it's my thought only, and it's not anyone else's thought. So this is the meaning of the second line. Patient recognizes the thought as a product of their own mind. And when this thought is coming in my mind that my hands are unclean, I don't like it. I don't agree with that thought. I know it's a senseless thought. I know it's a stupid thought. I know that this thought is coming unnecessarily in my mind. So I find them excessive, irrational, and senseless. And at some point of time, I also try to resist that thought. I try to stop that thought. I try to neutralize that thought. So patient try to resist or neutralize the thought. So I know that this thought is not true, and that is what differentiates it from delusion. A patient who believes in the delusion, a patient who has obsession usually has insight present and knows that this thought is excessive and irrational. So I am getting this thought that my hands are unclean. It is making me anxious. I try to stop it, but I am unsuccessful. My anxiety is increasing. Finally, what do? I go and I wash my hands. So this washing of hand is a compulsion. When I wash my hand, it reduces the anxiety temporarily, and then again the cycle repeats. So compulsions are repetitive behaviors, or they can be mental acts also, which are performed in response to obsessions, and they reduce anxiety temporarily. So when I was having those thoughts of obsessions, I did not agree to them. And when I was washing hands, I do not like it. I'm a bit angry at myself that this is not required. Why am I doing it? I have to do it, but I don't like doing it. So neither do I agree with the obsessions, nor do I like the compulsions, which means obsessions and compulsions are ego dystonic, not agreeable to self. I don't agree with them. This is the meaning of ego dystonic. Now the neurotransmitter involved is serotonin, and OCD is one mental illness in which we know which circuit is involved. So there's a circuit in the brain, CSTC, cortico. So it starts from cortex, goes into striatum, from there to thalamus, and back to cortex. You can visualize it as a loop. A thought is getting stuck in this loop, right? That is why it is coming again and again, again and again in the mind. Sometimes to explain the patient, we say that imagine there's a loop and there's a filter. And now this filter is not working. So the thought is going in the loop again and again. That is why the thought is coming in your mind again and again. Now the most common presentation of OCD is the example that I just mentioned. Obsessions of contamination, that I am contaminated, my hands are unclean, followed by compulsion of washing, right? You wash. And you also avoid the places like public toilets. Like you avoid, say, buses. I had a patient, whenever he would travel with by a bus, he would avoid, holding on to anything in the bus, because, that rod on the top, it has been held by so many people, and he had OCD. So he would try to avoid touching that rod. So that is the avoidance. The second most common type of OCD is pathological doubt followed by compulsive checking. So say there's a patient, he's a shopkeeper, and every evening when he has to shut down the shop, put the shutter down, he gets a doubt, did I do it properly? Did I lock it properly or not? Now he remembers that he did lock it properly, but the doubt is coming, did I lock it? Did I lock it? And so what he does is, he repetitively checks it. He checks it again and again. He checks the lock again and again. This is pathological doubt with compulsive checking. In some patients, what we see is, there are intrusive thoughts about either aggression or some kind of sexual thoughts or religious thoughts. So what happens is, for example, say there's a patient, every time he passes in front of a mosque or a temple or a church, he gets a offensive thought against God. He gets a bad thought for God. And later on, he starts getting those thoughts even when he is not close to any of these religious places. So what he does, he gets a bad thought about God. He feels guilty about it. He, apart from everything, apart from the anxiety and all, he also experiences a lot of guilt. And what he does is, when he gets that thought, he prays. Gets that thought, he prays. So that offensive thought about God is obsession, and the prayer is a mental compulsion. There is no clear observable behavior here. He is chanting prayers in the mind. So that's a mental compulsion. So offensive thought about God is obsession, prayer is a compulsion. So this is the third kind of OCD. Then there is symmetry or precision with compulsion of slowness. So say there's a patient, he wants everything to be in perfect symmetry. If he's sitting to do some work, on the table, if there are two pens, they have to be at exact 180 degree. If one pen is at 178 degree, the person will start feeling anxious. He would not be able to start work until he keeps it back at 180 degree. So in creating things in a symmetrical manner, putting things in a symmetrical manner, the work gets slowed down a lot. And finally, magical thinking. Just because they thought about an event, it will occur in reality. This is a thought. Like say the patient says that I have this thought that, in fact, this is a real case. One of my patients, she had a thought that while coming back from the office to home, if I do not give money to the priest of the temple, my younger brother will die. So she would, every day she would go and give money to the priest. The priest was pretty happy, right? But this is magical thinking. Just because the thought came in my mind, it will actually happen. So the most common presentation of OCD is obsession of contamination followed by compulsion of washing. But if somebody asks you separately, what is the most common obsession, what is the most common compulsion? So obsession remains the same, obsession of contamination. But when it comes to compulsion, it is compulsive checking, not compulsive washing. Usually, in a patient, we see many types of obsessions and many types of compulsions. But if you are asked to pick one on the basis of frequency, this is the answer. Treatment again remains the same, combination of medications and therapy. For medications, you can give SSRIs and clomipramine. Clomipramine is a TCA, tricyclic antidepressant. And what are SSRIs? Selective serotonin reuptake inhibitors. All right, and you can also use antipsychotics as augmentation. And the therapy, all of you know, ERP, exposure and response prevention. Some books says it is a type of behavioral therapy. Some say it is a kind of CBT. This is the therapy of choice. All right, hoarding disorder. So what happens in hoarding disorder? The person is not able to get rid of things that she does not even require anymore. Like a 25-year-old girl will come to your clinic and she will say that the pencil box she used to use in class first, the belt she wore in class second, the notebook she had in class third, the tie she had in class fourth, everything is lying there at her home, right? She is not able to throw anything. She keeps on collecting all these things and the house is full of garbage. Whenever she wants to throw anything, a thought comes in the mind, what if I need it later? And she keeps it back. So the house keeps on becoming full of garbage. It gets cluttered. There have been case reports when the garbage has fallen onto the patient, leading to death also. So this is holding, inability to discard the items because they are afraid of losing something important. In the older classification, holding was considered as a subtype of obsessive compulsive disorder. But in the newer classification, it has been made a separate diagnosis. Treatment remains the same, SSRIs and cognitive behavioral therapy. ERPs is not as effective as it is in OCD in patients who have holding disorder. Then the third, so we are talking about obsessive compulsive and related disorders. We talked about OCD, we talked about holding disorder. Now we are talking about body focused repetitive behavior disorder. Look at the name, body focused repetitive behavior disorder. So basically, there is a repetitive behavior which is focused on body, and usually it involves behavior focused on either skin or hair, right? So focused on skin or hair and inability to stop them. For example, trichotillomania. In trichotillomania, what happens? The person has this urge to pull out the hair, an urge to pull out the hair, right? Usually patient tries to resist it, but the urge increases. So finally they pull out the hair. It may be scalp hair. In some patients, it may be eyebrows and even eyelashes. And some of these patients will pull out the hair and then they will swallow it. So the swallowing of hair is called as trichophagy. Now, if you are swallowing hair for a long period of time, that hair may accumulate into a ball in your small intestine or stomach. So ball of hair, and it may obstruct the small intestine or stomach. You may experience abdominal pain and you are taken to the hospital. The surgeon opens you up and from there comes out the ball of hair. That ball of hair is called as trichobezoar. That ball of hair is called as trichobezoar. So this is trichotillomania. In some patients, there is repetitive picking of skin. So they will pick the skin. They will take out the skin. and there are injuries on the face, or sometimes they pick the skin just below the nails, and then they try to put bandages to hide it. Even patients who have trichotillomania, they develop bald patches, so they may try to hide it by putting a wig or something of that sort. So repetitive picking of skin is called as excoriation disorder. And body dysmorphic disorder, again look at the name, body dysmorphic. So these patients have a preoccupation with the idea that there is something wrong with their external appearance, right? They believe there is something wrong with their external appearance, but when you examine them, either you find that there is nothing wrong, or you find that there is slight anomaly, which anyways is there in everyone, right? Nobody has a perfect face and body. So preoccupation with an imagined defect in the physical appearance, like a patient may come to you and he may say, I believe I have a very long nose, or I have a very short nose. I have big lips, thin lips, big ears, small ears. And when you examine them, you find everything in the range of normalcy only. But the patient is preoccupied with it, and the patient indulges in repetitive behavior also. Like say a patient believes that his nose is too long. Now he's trying to put wrap a cloth around his face every time he comes outside the house, because he thinks that others will be looking at me. If somebody smiles, he thinks that he's laughing at me. Some of these patients would go to the plastic surgeons and would demand that the surgery be done, right? So this is body dysmorphic disorder. It usually involves hair, nose, or skin. Treatment is primarily CBT, and you can also use SSRIs. So these were your obsessive compulsive and related disorders. Let us talk about trauma and stressor related disorders. Now see, the name itself tells us that these disorders follow a traumatic event. If there was no trauma, these disorders would not happen. So first of all, we will talk about PTSD, post-traumatic stress disorder. Now PTSD follows significant trauma, something which is very serious and which can overwhelm anyone, like say natural disasters like flooding, say earthquake, or war, or some serious accident, rape. See, all these traumatic events which can overwhelm anyone. What are the symptoms of PTSD? We have classically 3 symptoms. First are intrusion symptoms. Now what happens is, let's take an example. Say I went to Hyderabad to take a class. I often go to Hyderabad, and I was driving in Hyderabad and I was hit by a truck. Now I survived, I did not have any injury, but the accident was bad. And say I have developed PTSD now. One of the symptoms would be intrusion symptoms like flashbacks. So say this accident happened 4 months back. Today in Delhi, I am taking a class. Suddenly, I would re-experience the event. I would feel as if I am driving the car and I am about to be hit by the truck. That accident would flash in front of my eyes. Not only that, I may experience as if all of that is happening all over again. I may experience that I am actually again driving a car and a truck is approaching me. So the flashback of that accident comes to me. I have flashbacks of that accident. Repetitively, I have memories of the same accident. Even when I sleep, I have nightmares about the same accident. So these are called as intrusion symptoms, where the same event is experienced by me in different forms. So flashbacks, memories, nightmares. Second symptom is avoidance. Now I will try to avoid anything or everything related to that trauma. Say I had gone to Hyderabad for a class. Now I have stopped teaching, because the moment I start teaching, I am reminded of the trauma. Maybe I've stopped driving, because the moment I sit on the driver's seat, I am reminded of the trauma, so I avoid it. I may go to the extent that I have stopped eating biryani. Why? Because biryani reminds me of Hyderabad, which reminds me of the trauma. So anything and everything that can remind me of the trauma is avoided by me. And I also have arousal symptoms, anxiety symptoms. So these are the 3 symptoms that are seen in patients with PTSD. The symptoms must be present for at least 1 month for us to make the diagnosis of PTSD. In case everything else is same, but the symptoms are less than 1 month in duration, in that case we make the diagnosis of acute stress disorder, not PTSD, but ASD, acute stress disorder. All right. What is the treatment? The treatment of choice is trauma-focused cognitive behavioral therapy. You can give medications like SSRIs. A psychotherapy called as EMDR was created specifically for the patients of PTSD, eye movement desensitization and reprocessing, but it was found that CBT has better efficacy. So CBT remains the therapy of choice. So PTSD is following the traumas which are very serious in nature. What about the stressors that happen in life? Like say you had a breakup. Say you had a breakup and the person with whom you broke got into relationship with your best friend. Is it traumatic? Yes. But this is something that is not uncommon in the course of life. Relationship problems do happen. So you had a breakup, you had a financial issue, you lost your job, you have say death of a loved one, or you had to migrate. All these things are traumatic, but they do happen in the course of life. So such events can lead to what is called as adjustment disorder, right? So all these things. So what are the symptoms that we see? We see anxiety and depressive symptoms. After the trauma, patient can develop anxiety and depressive symptoms, and the treatment is again primarily psychotherapy. So if the question is talking about these kind of events, then, and if the question is giving you symptoms, anxiety and depressive symptoms only, then you have to make the diagnosis of adjustment disorder. How would you know whether you should make the diagnosis of depression in such cases or adjustment disorder? Because a trauma can also lead to depression, huh? That is also possible. The same thing that we studied in the case of dysthymia. When the examiner wants you to make the diagnosis of adjustment disorder, he will give you history of a stressor, and then he will give you mild symptoms and usually some kind of negative history also. For example, a 33-year-old female lost her job, and for the last 3 months she presents with sadness of mood, occasional crying spells, occasional sleep disturbances. But when she is with her family, she reports that she feels okay. Now this line that when she is with her family, she reports that she feels okay is a negative history given to you so that you don't make the diagnosis of depression, but rather think about adjustment disorder. This negative history should tell you that the symptoms are not that severe, right? So this is adjustment disorder. All right. Now let's talk about somatic symptoms and related disorders. Earlier it was called as somatoform disorders. So basically somatic means physical. Now here the patient is presenting to you primarily with physical complaints. The symptoms are physical, the cause is psychological, right? The first one is called as somatic symptom disorder or bodily distress disorder. This is the name in ICD, this is the name in DSM. Somatic symptom disorder. It's in the name, somatic symptom disorder. So the patient is primarily going to come to you with a somatic complaint. It could be anything. The patient comes and tells you that he's having a lot of bloating in the abdomen, or there's a lot of pain, paresthesias, right? There is some somatic symptom for which you cannot find any medical cause, right? For which you cannot find any organic cause. But that is not important, right? What is more important is there is some somatic symptom and patient appears to be completely preoccupied with that symptom. The patient is excessively preoccupied with the symptom. The patient comes to you, says that doctor, I have bloating in abdomen. And then you are discussing with the symptom with the patient, but everything is linked to that bloating. Even if the person is talking to someone, say the friend asks him what is happening in life, he'll say life is good, but there is bloating in the abdomen. What is happening in your career? I'm going to the office. I might get a promotion also, but the only thing that is holding me back is bloating in the abdomen. How's your personal life? You were dating someone? Yeah, I'm dating somebody, but the problem in the dates is the bloating in the abdomen. So you are like that. Even if there is bloating in the abdomen, this guy is excessively preoccupied with it. There is excessive thinking, excessive behavior, excessive emotions attached to that particular symptom. That makes it abnormal, right? And often when there are stressors in life, the symptoms increase. When the life is peaceful comparatively, the symptoms decrease, right? So the patient who has somatic symptom disorder is preoccupied with the symptoms. On the other hand, the next diagnosis is illness anxiety disorder or hypochondriasis. Now look at the name. Anxiety is about illness. Now this guy is preoccupied with the diagnosis. This guy is preoccupied with the idea that I have a serious illness. The last guy was preoccupied with the symptoms. He was saying there's bloating in the abdomen. This guy will say I have stomach cancer. He is preoccupied with the illness. So here the preoccupation is with the idea that either I have a serious illness or I may acquire one. So the patient comes to you, patient says, doctor, I have stomach cancer. You are like, how do you know that? He says, after every meal I hear some kind of sound coming out of my abdomen. You tell him that is normal. That is called as bowel sound. It's normal. He says, no doctor, I have stomach cancer. Then you do all the investigations, CT, MRI, everything you do. You tell him that everything is fine. You have nothing. He says, okay, doctor. He goes back home and then goes to some other doctor and says, doctor, I have stomach cancer. This guy is preoccupied with the idea that he has stomach cancer. And that belief does not change, or that preoccupation does not change despite all the investigations coming out to be normal and the doctor giving the reassurance. So that guy was preoccupied with symptoms and this person is preoccupied with the diagnosis or illness. Conversion disorder, important for your exams. Multiple questions have been asked in the M.Phil entrance exam. Conversion disorder. In conversion disorder, what happens is the symptoms are neurological, but the cause is psychological. Neurological symptoms means there can be a motor symptom, like the patient may come with the paralysis. There may be a sensory symptom. Patient may say that I cannot feel the touch, or the patient may be having seizures, right? So symptoms are suggestive of some kind of neurological symptom. The interesting thing is the symptoms do not conform to the anatomical and physiological principles. What does it mean? Say a patient comes to you and patient says, doctor, I cannot feel anything in my hand. And usually what is done is you try to map which part is lacking the sensation. So when you do the mapping, you find out that upper half of the hand has no sensations, the fingers have no sensations, and the lower part has sensations. Now from the knowledge of anatomy, you know that there is no nerve which supplies only the fingers and not the remaining part of the hand. So the symptom is such that it is not conforming to the anatomy, the anatomical principles that we are aware of. This is very important. A lot of questions come from this. La belle indifference. The feeling of lack of, or the sense of lack of concern. Rather, I should just say lack of concern for the symptoms. That is la belle indifference. What does it mean? Say a young girl comes to you and she says, doctor, I am not able to see anything with my right eye for the last 3 days. And then she goes on to say, but doctor, that's okay. That's fine. It's not a big deal. I mean, my left eye is still working pretty fine. Not able to see with the right eye. That's okay. As if she does not care about it. As if the loss of vision in one eye is no big deal. This lack of concern for the loss of vision in one eye is called as la belle indifference. So it is seen in conversion disorder and more common in females. Now let's talk about dissociative disorder. What is the meaning of dissociation? In dissociative disorder, dissociation happens. So look at this long definition. Dissociation is the loss of integration, is the disruption in the normally integrated functions of memory, identity, consciousness, perception and motor behavior. What does it mean? Say I'm standing here, right? There are many mental functions which are happening simultaneously and in an integrated manner. What does it mean? I am conscious, which means I am alert, awake. At the same time, I am aware of my identity. I know my name is Dr. Praveen. I know I'm a psychiatrist. I know I'm a teacher also. I do have access to memory. I remember things that I've done in my life. I can see, I can hear, my perceptions are intact, and I can move myself, my motor behavior is intact. All of these are intact. Sometimes, because of a stressor, one of these mental functions get detached from the remaining mental functions. That is dissociation. For example, say a young girl is traveling in a train along with her family members, her parents. The train meets an accident, and in the accident, the parents die, but the girl survives. It's been 15 days since the accident. The girl has no recollection of that trauma. The girl has no recollection of that accident. The girl has no recollection of the fact that her parents died in that train accident. Why? The memory of that accident is so painful. The memory of that accident is so traumatic that her mind knows that she would not be able to tolerate it. So what the mind does, what the unconscious part of the mind does, what the unconscious part of the psyche does, it detaches or it removes that particular memory from the remaining memory and the remaining mental functions. A part of memory has been dissociated from the remaining memory and the remaining mental functions. This is dissociation at work. Onset is usually associated with some kind of stressor. Now, depending upon what kind of symptom patient presents with, we have different kind of dissociative disorder. The example that I just took is called as dissociative amnesia, in which sudden loss of autobiographical memory. Autobiographical memory means personal memory. Like this, say, imagine that the day that accident happened was also the day India got a new prime minister. So the patient would be able to remember the new prime minister's name, but would not be able to recall the accident. Why? The accident is personal. That is personally important. Prime minister is not so much important. So the loss is of autobiographical memory, right? Dissociative fugue. This is a question from your M.Phil entrance exam. So in dissociative fugue, what happens is there is a sudden unexpected travel. And the patient is not able to, there's amnesia for the travel and may involve assumption of a new identity as well. For example, say the person lives in Delhi and is under stress for some reason. Suddenly one fine day, patient makes a travel and say goes to Trichurapalli in Tamil Nadu. It's an unexpected travel because the person does not have anybody over there in Trichurapalli. But the person makes that travel. After reaching Trichurapalli, now he does not remember anything about the travel. And he may take a new identity. He may say the name of the person is Ram. He goes to Trichurapalli and after reaching there, he says, my name is Srinivasan, and starts doing some activity. Say he starts selling coconut water on the beach. So a travel, amnesia may involve a new identity. So dissociative fugue earlier was considered a separate diagnosis. Now dissociative fugue has been included under the broader diagnosis of dissociative amnesia. It is considered as a specifier because even in fugue, amnesia is happening. So we say that if there's a history of travel, we'll say dissociative amnesia with fugue. Dissociative identity disorder, multiple personality disorder. So what happens in the same individual? There are two or more personalities, sometimes called as alters in the same individual. And usually what happens is at one time there would be only one personality. If you guys have seen that movie, there's a movie called Aparichit, which is basically a Tamil movie called Onion. So in that movie, the protagonist, Vikram, he has got three personalities. At one time, there would be one personality, and the personalities are usually unaware of each other's existence, right? So this is called as multiple personality disorder or dissociative identity disorder. DPD, we talked about it. So depersonalization is feeling of unreality of self, right? So what happens in this? In depersonalization, person feels as if I am unreal. Patient comes and says, doctor, I feel unreal. I feel as if I am not me. I feel as if I am outside my body and as if I am watching myself. Like we watch characters in the movie, similarly I am watching myself. Right? So this is feeling of unreality of self is depersonalization. When the world feels unreal, patient comes and says, everything around me feels unreal. I feel it's not a real word, it's a fuzzy kind of word. That is derealization. So feeling of unreality of self, depersonalization, feeling of unreality of the world is derealization. Please remember that This is not a psychotic experience. When the person comes and says, I feel as if I am not real, the important word is as if. The person knows that nothing has really changed. This is just what I am experiencing. It's not reality. So the reality testing remains intact. What is the meaning of this line? It means that the patient, while having that experience, knows that in reality nothing is unreal. This is just what I am experiencing at this moment. This DPDR is very common. I mean, people who do not have any psychiatric illness, almost 60-70% of them can experience these symptoms once in a while. I have experienced it when we were doing duties. When I was doing my MD, we would have long duties, 24-hour, 30 hours duties, and we would not get to sleep. So when you're tired, when you're sleep deprived, when you're fatigued, these kind of experiences may happen. I'm sure some of you must have experienced these things. All right, so till now, whatever symptoms we studied, whatever disorders we studied, the patient was not faking any symptom. This is the first time we are saying that the patient is faking symptoms, factitious disorder or Munchausen syndrome. Now the patient produces symptoms to get medical attention, and the patients are usually related to medical field. So what happens is, say there is a nurse, she has access to medical literature. Say she reads the history of appendicitis. What is the clinical presentation of appendicitis? She reads in a book, and then she goes to the emergency and says the same thing. She goes to the doctor and says, Doctor, I am having pain in abdomen. It started near my umbilicus and it is gradually moving towards my right iliac fossa. Now this is the classical presentation of appendicitis, acute appendicitis. The doctor at duty, a young doctor, listens to the history and he is like that this is a classical presentation of acute appendicitis, and he admits the patient. This is what the patient wanted. She wanted medical attention. The stories about the symptoms that the patients make, these stories are called as pseudologia fantastica. Pseudologia fantastica. So you admit the patient and then you do the test, you find nothing. Patient is continuously saying that she's having pain, she's having severe pain. So what do doctors do? They'll call the surgeon and the surgeon will say, okay, we can't find anything on investigations. Let's open up and let's see if there's something going wrong. This is called as laparotomy, right? Exploratory laparotomy. So you do the laparotomy and you find nothing. And then you tell the patient that you don't have any symptoms. There's nothing wrong with the body and your symptoms are weird. I'm not sure whether you are saying the truth or not. So when you say so, the patient gets angry and then she leaves you. She leaves your hospital, she goes to another hospital and she says the same thing, that I'm having pain in the abdomen. Right? So because these patients often undergo surgeries, you will find the signs from previous interventions. Like what is grid iron abdomen? If there are multiple scars on the abdomen no longer remains soft. Right? It becomes stiff. So that is what is called as grid iron abdomen because of scars from the surgery. So because these patients want medical attention and they try to keep going from one hospital to another, sometimes they are also called as professional patients, and this disorder is also called as hospital addiction or polysurgical addiction. So these patients assume a sick role. Once you admit them, they want that they should be treated in such a way as if they are very sick. They want the doctors to come and meet them thrice a day. They want the nurses and come and meet them thrice a day. They want special attention as if they are very sick. This is the meaning of sick role, that they want everyone to behave with them as if they are very sick. So if somebody is producing symptoms or faking symptoms himself or herself, we call it Munchausen syndrome. If somebody is faking symptom in the dependent, like in the children, then we call it Munchausen syndrome by proxy. So say a mother brings her child to the pediatrician and says that whenever he urinates, he cries. The doctor asks for a urine sample. So while collecting the urine sample of the child, the mother pricks her finger and adds a drop of blood in the urine sample. When the report comes, it says RBCs, red blood cells in the urine, and the child is immediately admitted to find out what is causing this bleeding. This is Munchausen syndrome by proxy. This is a question from your M.Phil entrance exam. La belle indifference is seen in? The answer is, of course, conversion disorder. Alright, quickly we'll talk about substance related and addictive disorder, which is not so commonly asked in the exams, but some questions come in the exam. So first of all, we need to know what is dependence. When do we say that a person has become dependent on a substance? So there are certain criteria for the same. The first is tolerance. Increasing amount, what is tolerance? Increasing amount is required for the desired effect. So for example, you start drinking alcohol. In the beginning with 1 peg or 2 peg, you feel intoxicated, you feel high. But with time, you need now 6 pegs of alcohol to get the desired effect of feeling high. This is tolerance. You know, young people get very happy and they boast about it that, you know, I have a lot of capacity to hold my liquor. That's not a good thing. If you have a lot of capacity to hold your liquor, it means you are becoming tolerant to it, nothing else. Withdrawal symptoms. What are withdrawal symptoms? Symptoms that appear when you stop taking a substance. Say somebody is taking alcohol daily and suddenly he stops it one fine day, he'll have tremors, he'll have vomiting, he'll have nausea. These are the withdrawal symptoms. Craving. What is craving? An intense urge, a strong urge to take the substance. A very strong urge to take the substance that you can't stop yourself. Continued use despite harmful consequences. You are taking alcohol regularly. You know that your liver is getting damaged because of it, but still you continue to take alcohol. This is continued use despite clear harmful consequences. Neglect of alternative ways of pleasure. Earlier you used to enjoy watching football, you used to enjoy watching movies, you used to like going for plays. Now the only thing that you do when you want to be happy, when you want to have fun, is to take the alcohol. And the last one is inability to control. Inability to control substance taking behavior. What does it mean? It means that, say in the beginning you had rules that you would never drink more than 2 pegs of alcohol. You had rules that you would drink alcohol only on weekends. You had rules that you would drink alcohol with friends only. Now you are breaking all those rules. You are not able to control yourself. You continue drinking till the last drop of alcohol is left in the bottle. You drink all alone and you drink throughout the week. So you can't control your behavior. So I've taken the example of alcohol, but this is the same set of criteria that are applicable to all the substances of abuse. Now let's talk about alcohol screening. Alcohol screening. So if we want to know whether a person has alcohol use disorder, we can ask a couple of questions called as CAGE. So C stands for cut down. This is for alcohol only. You ask the patient, do you ever feel the need to cut down on your alcohol intake? Do you ever feel the need to cut down on your alcohol intake? A stands for annoyed. Do you get annoyed when people talk about your drinking habits? Do you feel guilty about your drinking habits? And do you need alcohol as the first thing in the morning to even get your day started? What happens is, people who are dependent on alcohol, when they get up, they are in withdrawal. They are having tremors, they feel nauseous. So what they start doing is, the first thing in the morning is they drink alcohol. So their day starts only when they drink alcohol. So this is the meaning of eye opener. Don't take it literally. It's not that you have to open your eyes, for that you need alcohol. No, you have to, if you want to start your day, you have to take alcohol. So if the person says yes to 2 or more than 2 of these 4, then that is screening positive for alcohol use disorder. This has been asked in your exam. Audit. So another test that can be used to find, that can be a screening tool for alcohol use disorder is alcohol use disorder identification test. Another one which tells you what is the severity of alcohol dependency is SADQ, severity of alcohol disorder questionnaire. Just remember the names. Now, if somebody has been consuming alcohol for too long a time, they may develop certain neuropsychiatric disorders, and the name of that neuropsychiatric disorder is Wernicke-Korsakoff syndrome. So Wernicke-Korsakoff syndrome is an amnestic disorder. What is the meaning of amnestic disorder? A disorder characterized by abnormality in the short-term memory. So Wernicke-Korsakoff syndrome has 2 parts: Wernicke's encephalopathy and Korsakoff syndrome. So let's talk about Wernicke's encephalopathy first, which is the acute complication caused by vitamin B1 or thiamine deficiency. The cause is the deficiency of vitamin B1, or another name for vitamin B1 is thiamine. What are the symptoms of Wernicke's encephalopathy? You can remember the mnemonic GOA. G stands for global confusion. The patient has confusion, is confused state. O stands for ophthalmoplegia. Weakness of eye muscles. Weakness of the muscles of eye, also called as extraocular muscles. So weakness of muscles of eye, weakness of extraocular muscles. And then A stands for ataxia. Ataxia means incoordination of muscles. Usually what we see is the patient is not able to walk properly. If he has ataxia, not able to walk properly because there is no coordination. So confusion, weakness of eye muscles, and incoordination, not able to walk properly. So if it is caused by thiamine deficiency, the treatment is also thiamine. So we give thiamine not orally in Wernicke's encephalopathy. We either give intravenous injection or intramuscular injection. So intravenous or intramuscular thiamine, high dose intravenous or intramuscular thiamine. Why so? Why high dose and why intravenous or intramuscular? Because people who have been consuming alcohol for many years, even the absorption becomes impaired. So when you give oral thiamine, they are not able to absorb it properly. And you want to reverse these symptoms quickly, so you want to give it in the form of injectable. So this is the acute complication. The chronic complication is Korsakoff syndrome. Chronic complication is Korsakoff syndrome, again caused by vitamin B1 or thiamine deficiency. The symptoms are primarily amnesia, memory loss, and also confabulation. This has been asked in our exams, confabulation. So there is memory loss. Say a patient comes back home in the evening and his wife asks him, where were you in the entire day? He does not remember it. So he makes a false story. He makes a false story to fill the memory gap. False story to fill the memory gap. This false story is called as confabulation. Say the patient says, I went to that relative and then both of us went to that park. Now this false story that he has created to fill the memory gap is called as confabulation. If it is caused by thiamine deficiency, what would be the treatment? Thiamine only. So long-term oral thiamine. long-term oral thiamine, and the prognosis is guarded. What does it mean? That prognosis is not so good. These patients do not always recover. That is the meaning of prognosis is guarded. So whenever you have to treat any patient who is dependent on any substance, the first step is always detoxification. And in detoxification, your primary concern is to manage the withdrawal symptoms. You want to manage the withdrawal symptoms. So the drugs that you use are benzodiazepines. For alcohol detoxification, we use benzodiazepines. Please don't think that it involves any kind of removal of toxins. That's not it. Primarily, you want to manage the withdrawal symptom. So once you have managed the withdrawal symptoms, you want that the patient remains abstinent, which means he does not restart taking alcohol. He does not relapse on alcohol. For that, what you can do, you do is you can give medications to decrease the craving. You can give medications to decrease the craving. So there are 2 drugs. I don't think they would ask the name of the drug exactly in your exam, but just for knowledge, you can remember it. There are drugs which can reduce the craving, naltrexone and acamprosate. And then there's a drug called as disulfiram. So what happens is, if the patient is taking disulfiram and on the top of it he takes alcohol, he would have a very unpleasant reaction in which he will have vomiting, nausea, right? This reaction is called as disulfiram ethanol reaction, because ethanol is alcohol, and if you take alcohol on the top of disulfiram, you will have this reaction. So basically what you are trying to do is, you are trying to deter the patient. You are making the patient afraid of alcohol. Why? Because the patient knows that I am taking this medication. If on the top of it I take alcohol, I will have a very unpleasant reaction. So because of the fear of that reaction, patient does not take alcohol. And then we have motivational interviewing. This is a psychotherapy technique. It is used to increase the motivation to quit any substance. And then our CBT, cognitive behavioral therapy, can be done. Another way of doing it is, non-medical way is 12-step self-help group, where people who have quit alcohol and those who are trying to quit alcohol, they come together and they help each other out, self-help. It's called Alcoholic Anonymous. Alcoholic Anonymous. Let's quickly talk a couple of points about other substances like opioids. The most commonly abused opioid is heroin. Heroin. The chemical name is diacetyl morphine. Interestingly, heroin was synthesized as a treatment for morphine addiction. But later on it was found that heroin is even more addictive than morphine. So heroin or diacetyl morphine. The street name is smack. You must have heard of this term smack. Smack is nothing but the street name of heroin. The drug peddlers and the users, they would not use the word heroin. They would maybe use the word smack. Apart from heroin, morphine is also abused and codeine is also abused. They are also opioids, right? Codeine is there in the cough syrups. A lot of people, they abuse cough syrup. They'll drink the entire cough syrup in one go. They'll drink 2 or 3 cough syrups bottle in one go. So they are abusing codeine. The treatment is, again, the first step, detoxification. So in detoxification, we manage the withdrawal symptoms, as I discussed. And for managing the withdrawal symptoms of morphine or codeine, we use these drugs. You need not remember the name exactly. Just remember that they are also opioids. They are also opioids, long-acting opioids. Long-acting opioids. And the good thing is, after detoxification, the next step of relapse prevention, we use the same drugs, methadone, buprenorphine. Basically, you are substituting one kind of opioid like morphine and heroin with another kind of opioid, right? And like we had Alcoholic Anonymous, we have Narcotic Anonymous here. So the drug names are not important, but you must know that detoxification is taking care of withdrawal symptom. Maintenance of abstinence is basically relapse prevention.